Good afternoon, everybody. It's my pleasure to introduce this monthly Grand Round, and we've got a particularly interesting topic that's right at the cutting edge of current science. Formal topic, it takes guts to get arthritis, the spondyloarthritis, Crohn's disease spectrum. Is there a new paradigm? Now, there's been a lot of work in the scientific literature over the last, 10 years probably, increasing the number of publications looking at the relation between the gut and everything actually, whether it goes from obesity to arthritis to mental health. And so it seems like the gut is a major focus of just about every discipline you want to talk about these days. So it is my pleasure to welcome Michael Schultz and Simon Stebbings to talk about that combination. One a gastroenterologist, one a rheumatologist, and I'm looking forward very much to hearing all this space integrated into one presentation. So handing over to who's going first?
I start?
Yeah. Okay, don't need that.
Nope. Thank you very much, Barry. Thank you very much for this nice introduction and homing in on the gut. Yes, Simon, why are you here?
It's all about the joints.
So you see it's starting out quite nicely, and we already had this discussion. So this can go either horribly wrong here this afternoon or this lunchtime, or it can actually be a quite useful discussion between the two of us. And obviously Simon and I have done this before, but I'll just take this down a bit, but not in such a formal way. Simon invited me to speak at the rheumatology meeting. So I was there in a room of 400 rheumatologists, and my task was to convince them that actually spondyloarthritis is a gastroenterological disease. So yeah, needless to say, I missed the margin by that much. I think he had some home advantage there, but we'll try this again. So on the agenda today is I'll tell you a little bit about Crohn's disease. Simon will tell you a little bit about spondyloarthritis. But then what we really want to bring across today is the overlap. The overlap that exists in the genetic sphere, in the microbiome. There's a lot of clinical overlap, which Simon and I have done some research on. That's the studies from Otago that we've performed in the last few years. We look at how can we treat not one disease or the other disease, how can we come to an agreement of treating the spectrum, and then we glimpse into the future and see what's going on in the future. Now, it starts off with inflammatory bowel disease before Simon will take over with spondyloarthritis. And needless to say, inflammatory bowel disease is an important disease. You might not think the numbers are particularly high, but they are on the increase. So at the moment, New Zealand probably has about 20,000 to 23,000 patients with inflammatory bowel disease. And this is reflected in Otago as well, that over the last few years, and this is some research that I've done together with Kirsten Koppel, who just talked to me about the revision of the paper because that's on the brink of publication, that we had an increase here in Otago as well. And if you look at the slide down here in the corner, this is the bell-shaped curve, how this disease is in the world. And you can see Otago, Nelson, and Christchurch are right at the upper end of this bell-shaped curve. So that means we really have a lot of this disease, and we're probably almost leading the world here in terms of incidence. Now, what is inflammatory bowel disease? It's Crohn's disease or ulcerative colitis, and we have a few patients left over that we can't classify. These patients, they have a picture that could fit both, and some of those patients do declare themselves as either having Crohn's disease or ulcerative colitis down the road, but initially they might not be so easy to explain. But if you do a colonoscopy on those patients, you see right here, ulcerative colitis does look quite different to Crohn's disease. Crohn's disease has big ulcers with just kind of seemingly normal mucosa in between, whereas ulcerative colitis is a continuous disease. Histologically, we also have this picture here that ulcerative colitis is more affecting the surface. So it's a surface disease, and that kind of tells us a little bit about the clinical presentation of this disease as well, whereas Crohn's disease is transmural. So the inflammation goes right down through the wall of the gastrointestinal tract, and it can therefore lead to abscess formation and fistulization and things like that. The distribution of the disease is also quite different. Ulcerative colitis, and the name takes it away, is located in the large intestine. Most patients have perianal involvement, but then it works itself up, left-sided colitis or pancolitis. Whereas Crohn's disease can affect you really from top to bottom. It can start with mouth ulcerations and can go all the way through to the other end with perianal Crohn's disease and everything in the middle. This is obviously reflecting then also the clinical presentation. Patients with Crohn's disease often present with weight loss, but not so much with bloody diarrhea as patients with ulcerative colitis would do. Despite the disease being known for many, many, many years and lots of research, and Barry alluded to that, into these disorders, we're kind of not really much closer to knowing actually where this disease comes from. So this theory that my previous mentor, Balfusato, put on here in 2006 pretty much still stands. It was like that 10 years before he put it into this nice colorful picture, and it still stands that inflammatory bowel disease is probably a multifaceted disease. It has to do with aberrant microbial antigen presentation, aberrant immune response, some environmental triggers, and obviously all that needs to happen in a genetically susceptible patient. So if we take this into detail, evidence for genetic susceptibility was long known because we know that there is a family history in a lot of those patients. When we have new patients presenting with inflammatory bowel disease, quite a number have a family history, 5 to 15, and you can drill this down a little bit further and look into siblings. The risk is about 2 to 5%, right up to 2 parents, it's up to 36%. You wonder where these 2 parents met, probably in one of the support groups, and then exposing their children to this high risk of also having inflammatory bowel disease. And over there on the other side, you see the risk in monozygotic and dizygotic twins. So Crohn's disease really high in monozygotic twins, whereas not so much the ulcerative colitis-like picture. I don't want you to ask to stay away from these lovely food outlets here, and this is not really the topic of this talk. It's just kind of exemplifying the westernization that takes place, and probably with the westernization, the rise of these autoimmune and inflammatory bowel diseases. We clearly see that where there is lots of coffee cups, you have lots of inflammatory bowel disease. Where there's a big golden arch, we have lots of inflammatory bowel disease, whereas around the equator, we have less of that. Now, that obviously has to be taken with a little bit of a grain of salt here, because these countries that are around the equator, the health system is obviously not as developed as the health system on either sides of the equator. Maybe we don't look at that so much. Maybe we don't find it so much there. But on the other hand, other factors play a role. There are infections in these countries much higher than in the countries further away from the equator. So maybe that's a protective role. If you have helminthic disease, it's been shown that this is possibly protecting against inflammatory bowel disease. So all that comes into the game. But what we see more and more is that countries that now come into a Western influence sphere and westernize much more, in those countries we can identify a vast increase of inflammatory bowel disease. And this is true on this graph here as well, which then really looks at the incidence of inflammatory bowel disease. Again, the picture that I showed very early on was that down here, little New Zealand in this corner, at least I found a map where New Zealand is on, but in this corner here, very high incidence of inflammatory bowel disease, amongst the highest of the world. So that makes this disease quite interesting. How do we diagnose this disease? Well, it's a disease of the intestines, and how do we do this best? We do a colonoscopy on these patients, or we do a capsule endoscopy, and for a few years now, we can do also an MRI scan, which is over here, which shows a lovely picture of a thickened bowel wall with some dilatation here and a narrowing, probably a stricture further down towards the, further down here. So Crohn's disease, again, we have these big ulcerations here, and ulcerative colitis, we have more this kind of homogeneous ulcerated pictures. The capsule endoscopy is a tool that can look into the small intestine. So patients get a small capsule to swallow. They carry a little receiving device with them, and for about 8 hours, the capsule will send pictures to this receiving device, and I can then spend 2 or 3 hours looking at a monitor, a marvelous film of the capsule traveling through the small intestine, and we can count these ulcers here in patients with small intestinal inflammatory bowel disease. What we shouldn't forget, though, is that both of these disorders are multisystemic disorders. They are not just affecting the gut, and it's quite known that a lot of other presentations can happen with inflammatory bowel disease. We do see after stomatitis, we see arthritis, uveitis, we see oligoarthritis, and this is where Simon comes into the game. Some of these manifestations are related to the gut inflammation, some are not, but that's something that makes them then very difficult to diagnose. But anyway, the disease can present in a lot of different presentations. If we home in on the joint and skeletal system a little bit, so we see here the extra-intestinal manifestations, all of them are between 15 and 20%, in Crohn's disease a little bit higher. Some of these are dependent on the bowel disease activity, like oligoarthritis and so on and so forth. Some are independent, and there we have the ankylosing spondylitis. About 10 to 11% of all our patients will develop a spondylitis-like picture, which then brings Simon onto the plan to talk about that.
Thank you, Michael. Yes, so now we get down to the interesting bit, which is patients who actually develop spondyloarthritis within this context of inflammatory bowel disease. So the spondyloarthropathies is a sort of concept of interrelated disorders, which has really come together over the last sort of 15 years. So it's a spectrum of conditions which has a very strong familial predisposition, tends to run in families. And the most typical form is ankylosing spondylitis, which has been identified really for the last 100 years. And spondyloarthritis, the key aspect of this condition is inflammatory back pain, which particularly affects the sacroiliac joints. And that's the predominant presentation in these groups of conditions. But about 40% of patients will also develop extra-articular manifestations at some point during their disease. So these are the cardinal features of inflammatory back pain, which differentiate it from mechanical back pain. There are 5 ones which have really been identified by international consensus. So you can see from this that one of the key aspects is that patients present young, so usually in their late teens or early 20s with inflammatory back pain. It tends to be insidious, it's improved by exercise, unlike mechanical pain, and gets worse with rest, and often people will wake at night with pain. And one of the important aspects of the ankylosing spondylitis spectrum is its effect on quality of life. So if we look at this graph here, this table, we can see a range of different conditions here, and these are quality of life measures in the EQ5D. And what you might see from that is that across a range of all these different manifestations of quality of life, people with ankylosing spondylitis come off worse than other chronic conditions, including those with cancer. So this is a very serious condition in terms of patient quality of life. And this is sort of illustrated by this famous picture of a US airman in the 1940s and his progression over a period of 30 years with his ankylosing spondylitis, from a fit man to someone who's very disabled. So beyond the articular system, the axial involvement in the spine, there are a number of other areas which are involved too. So initial presentation is usually with inflammatory back pain, and then you get this late ankylosis occurring particularly at the sacroiliac joints, but also in the lumbar, thoracic and cervical spine. And also involvement of the ribs and the costovertebral joints, which can affect breathing. And then other aspects include peripheral arthritis, which often affects the lower limbs, and this cardinal feature here, which is enthesitis. And this is felt to be perhaps the first lesion in the condition. So probably the initial site of pathology is at the enthesis, where tendons attach to bone. So this is common at the tendo Achilles here, and we can often see that shown on an ultrasound scan as well, with inflammation showing up there. And often the involvement is very widespread, and I think this is why quality of life is affected. So I quite like this bone scan here, and it just shows the extent of the involvement throughout the spine, the sacroiliac joints and the sternoclavicular joints. It's a very widespread condition, really, and that's why it's so detrimental to quality of life. So Michael has already talked about extra-intestinal manifestations of inflammatory bowel disease. I like to think more of extra-articular manifestations, really, of which inflammatory bowel disease is one. Around about 40%, nearly half of patients with ankylosing spondylitis will develop an extra-articular manifestation. Depends a little bit how you define that. Some would say a lot more do, but in terms of the common associations which have a genetic and immunological link with inflammatory bowel disease and ankylosing spondylitis. These are the ones that we see. So uveitis affects about half of patients, and as you can see, up to 20% of people will develop inflammatory bowel disease within the context of ankylosing spondylitis of those who have extra-intestinal manifestations. And these manifestations really affect quality of life too. So this is dramatically shown with psoriasis, of course, which is a very obvious way of seeing the effect that it can have on people, and also with uveitis, which is very painful and often really affects people's ability to work for short periods, and people will get recurrent episodes of uveitis throughout their disease, and the incidence of uveitis increases the longer you have ankylosing spondylitis or another spondyloarthropathy. And if we think about the spectrum of disease now, then this is the new paradigm really. So I'm putting inflammatory bowel disease within the spectrum of spondyloarthritis. And we can see that, as Michael has said, these extra-articular or extra-intestinal manifestations like psoriasis and uveitis span the spectrum. And at one end, we might think of people having ankylosing spondylitis, the typical axial spondyloarthropathy, and at the other, inflammatory bowel disease. But across the range, we see a sort of gradation of manifestations through reactive arthritis and psoriatic arthritis, but all interrelated conditions immunologically, genetically, and clinically. So if we come to the genetics of ankylosing spondylitis and the spondyloarthropathies, like with inflammatory bowel disease, but with knobs on, we've got a strong familial history and genetic predisposition. So unlike the paltry monozygotic twin correlation in inflammatory bowel disease, 75% of monozygotic twins with ankylosing spondylitis will have a concordance with their disease process. And if you have a sibling or a parent, a first-degree relative with ankylosing spondylitis, your risk of developing that yourself is 90 times that of the general population. So a very strong, complex genetic inheritance, the most strong association in human disease. And this is predominantly associated with one gene in particular, the MHC class 1 gene HLA-B27, which many of you will have heard of. And here's the gene. It looks a bit like a baseball glove waiting to capture antigen. So it's for antigen presentation, this gene. And if you have HLA-B27, you have a 40 times risk of developing spondyloarthritis. But this isn't the whole story, because when you look at the general population, a lot of healthy people have B27. So in New Zealand, for instance, nearly 10% of the population carry this gene, a little less if you're Maori. So what are the other genetic risks which confer additional risk on top of this gene? Well, we do know that many other genes feed into this, and we can see this because with your increasing distance of relation from people, your risk falls dramatically. So if you have a first-degree relative, you have a very high risk here, but once you get to second or third-degree relatives, the risk falls off dramatically. And this demonstrates that this is a polygenetic disease which has a number of other genes involved. Interestingly, if we look beyond this B27 gene into these interrelated genes, we can see quite a strong co-risk with inflammatory bowel disease. So as we've seen already, very strong risk in first-degree relatives, 94 times. With inflammatory bowel disease, if you have a first-degree relative, it's a paltry 4.4%, so much less genetically inherited. But look at this cross-risk here. So if you have ankylosing spondylitis, you have almost the same risk of developing IBD as if you had a first-degree relative with inflammatory bowel disease. So a very strong co-correlation there between these two diseases. And there's a wide variety of immunological target genes which have been elucidated over recent years, and more have been coming out with GWAS and genetic studies. So in total, up to the present time, I think round about 200 to 300, it's changing every week really. The genetic burden is being teased out, but some of these may only have a very small cofactor in the development of these diseases. So that kind of leads us on to the next bit, which I might let you talk about, Michael.
Thank you.
Which is environmental triggers.
Thank you very much. It's funny what people are proud of. Genetics is nothing to be proud of, is it? Just going one word on the genetics. I mean, obviously that helps a tremendous lot in looking at the clinic of these patients, because it makes you aware of what you should be looking for. And when Simon and I started working together, suddenly more and more patients came forward with this kind of coexisting problem, because patients that I see would tell me, why should I tell you about my back pain? Because you're my gut doctor. You don't deal with back pain, and I'm sure Simon had the same problem. Why should I tell you about the frequency of my bowel motions when you are just interested in how my joints are feeling? So you really have to tease it out. And once you start doing that, more and more patients will come forward and actually admit to, well, now that you're asking, yes, I actually can't function in the morning. It takes a little while until I'm more active, or I have my pain in my lower back, and I'm pretty sure you saw the same thing happening with frequency of bowel habit and stuff like that. And we talk about that clinical presentation a little bit later. Now, besides the genetic overlap, there's a big overlap in the microbiome, and obviously the microbiome, the human microbiome, has been the flavor of the recent years. I think personally it's still in the developmental phase. We'll see whether that leads us somewhere. Personally, I'm a little bit disappointed with the genetics, because we get more and more of these genes being identified. But in clinical practice, they don't really help us. You have 25 risk factors for inflammatory bowel disease. So what? And I have also 25 bowel motions. So that's kind of a little bit difficult to tease out there. And I'm not quite sure if the studies on the human microbiome will go the same way. But it's a fascinating area to be involved in. It's the largest reservoir of commensal bacteria in the GI tract, and it harbors a tremendous amount of species. 500, I thought it's more 1,000 in the meantime, because again, like with the genome, you get more and more the more you can find by refining techniques. So what role does the human microbiome play here? Now, if we look at one of the older studies, and I was lucky enough to be involved in this lab where the study was done, if you take an animal model that is HLA-B27 positive, so according to Simon, it's a predisposition to develop ankylosing spondylitis. If we raise this animal model in germ-free conditions, nothing will happen. This animal, a rat at this point here, this animal is very happy in the germ-free condition and will not have any signs or symptoms. However, if this animal is then raised under conventional conditions, this rat will develop colitis and arthritis. And you see this here. This is a heavily inflamed colon with a vastly thickened inner lining, a vastly thickened mucosa, lots of inflammatory cells in here. Simon tells me that this is a joint here, and it also looks inflamed because it has a lot of pink in there, which kind of brings us to the end of my histopathological knowledge. But if you then look at these pores here, they are heavily inflamed and thickened pores, and this animal will drag their hind feet behind them because they're really painful. But as I said, this only happens if this animal is under conventional conditions, so is not sterile, is not in a germ-free condition. And this was like one of the first hints that you need more than just a genetic susceptibility to bring this disease to the forefront. Now, one of the difficulties with studying the human microbiome is obviously that the technology is changing, and this is why we're finding more and more of bugs that might or might not be involved. And every week we will see a publication somewhere that says we found the bacterium, the organism that explains this and this disease. In the past, we relied on culture techniques. Now we're way past the culturable bacteria, and we do the ion torrent blast sequence analysis, which tells us much more about the microbiome, what's actually happening there. But not only the improvement in technology will be responsible for that, the microbiome is a very difficult organism, so to speak, to study, because it's being affected by a lot of factors. Not only the age, so it will change with age, and then there will be this very long period where it's quite stable until it changes again, but also what shapes the microbiome is genetics, is the route of birth, geography, where do we live, what kind of hygiene do we have, how many medications are we exposed to. All these kind of things will play a role in the shape of our microbiome. And it can be used as a sort of fingerprint, the microbiome, because everybody has a different microbiome, and you can distinguish people on their microbiome. Now, taking that into account and then trying to find out what's different in certain diseases just adds another layer to the complexity of all that. Not to say it hasn't been done. This is a slide that shows you how different the microbiome is in certain disorders, especially in inflammatory bowel disease. And if you look at those people down here, this is inflammatory bowel disease patients. The first two is normal controls. So there are a lot of bacteria that are expanded in these kind of conditions. And we talk more about a dysbiosis in these disorders, so not a microbiome that looks similar to a healthy person, but more a microbiome that has certain species expanded and might play a role in the explanation of this disease. Now, Simon was involved in a review article. Do you want to comment on that,
yes,
what you did there?
So we looked at literature, this was a couple of years ago now, looking at particular bacteria that have been associated with spondyloarthritis, and quite a few have been identified over time. I think as we get a more complex knowledge of the microbiome, I think the idea that specific species are involved is rather too simplistic. But certainly some bacteria have interesting properties which might make them more prone to causing bowel inflammation and act as triggers. So these ones here, for instance, sulfate-reducing bacteria have a particular way of stimulating the mucosa and causing inflammation by release of toxic metabolites. And that's one of the things that is really coming up, this idea of metabolomics. So not only do we have to know what bacteria are there, but we have to know what those bacteria are doing. And some of the studies in Crohn's disease have really identified different metabolomic signatures in different patients. So that's quite interesting. We sort of a few years ago now went along the line of looking at how we might maybe modify the microbiome to make it less pro-inflammatory. And we did a groundbreaking study, really, with our colleague Katie Jenks, who's on sabbatical at the moment, having a nice holiday in Copenhagen. But Katie did a study with Michael and me for her master's and looked at 63 patients, and we divided them into two groups. And we gave them a probiotic here, this Bliss, with a range of different healthy bacteria, including lactobacilli. And we looked at a number of outcome measures to see how great this probiotic was going to be in curing disease. But unfortunately, it had no effect. So sad face emoji for that one.
It did have a strong placebo effect. I had patients coming to clinic, probably you as well, who begged us to continue in the study because they were doing so much better. But you know how clinical trials go. There's an end to everything, and especially if it's not working, you don't really carry on. Luckily, probiotics are available over the counter. The idea that patients with ankylosing spondylitis or spondyloarthropathies in that matter have gut inflammation, and looking at this gut inflammation is obviously not new. This has been around for a long time, and this study here was quite interesting. It's an old study from 1988 in the British Journal of Rheumatology. So what these investigators did is they looked at inflammatory gut lesions in a big number of seronegative spondyloarthropathy patients, 232 to be exact, in some control patients. Now in rheumatoid arthritis, 65% of those patients had inflammatory gut lesions. Ankylosing spondylitis patients, 57, mainly in patients with peripheral arthritis, or the few that are HLA-B27 positive. In the controls, they studied, sorry, you are being bored here. Try to be more interactive here. In the controls, there were no patients with any lesions in their gut. So that kind of showed already the high prevalence of these gut lesions in those patients. And Simon talked earlier on about the first-degree relatives. Now, there was a study in 1986 where patients with inflammatory bowel disease were studied, and their first-degree relatives, as well as spouses that lived with them. And unlike this study here in the inflammatory bowel disease study, the first-degree relatives were challenged with a dose of aspirin because we know that aspirin will disturb the intestinal permeability. So all of these first-degree relatives showed a heightened response to just one dose of aspirin with their intestinal permeability. And this study was then in a way replicated here in patients with ankylosing spondylitis just without the aspirin. And 3 groups were chosen, patients with ankylosing spondylitis, first-degree relatives and their spouses that lived with them. And this was really to tease out what's genetic and what's the environmental factor, so to speak, because they shared the same environment. As expected, HLA-B27 positive, where almost 90% of all patients with ankylosing spondylitis. First-degree relatives, still 57% were positive, and it wasn't available in the spouses that this wasn't measured. But what they looked for, the authors, was the fecal calprotectin. Now, just on a sub-note, fecal calprotectin is a stool marker that we can measure, and it's basically the product of inflammation in the intestine. It's a very sensitive marker for intestinal inflammation, not very specific to where the inflammation comes from. So I always tell my patients, you know, you can bite your tongue and that gets inflamed, and then you poop it out the other end, and I will find a raised fecal calprotectin. Doesn't tell me whether your large intestine, your small intestine, or even higher up is inflamed. So the fecal calprotectin was measured in those 3 patient groups, and it was significantly elevated in patients with ankylosing spondylitis. So that was certainly a surprise. But what was even more a surprise is that it was also significantly elevated in patients, in first-degree relatives who weren't patients. Those people didn't have ankylosing spondylitis. So that was quite remarkable. The spouses didn't have an elevation of their fecal calprotectin. So that was interesting. What became then more interesting was that there was this high prevalence of subclinical intestinal inflammation, because all of these patients didn't complain of any symptoms, but it was irrespective of the HLA genotype in those patients. So obviously the intestinal inflammation, I think some of the things we talked about earlier on, Simon, did indicate that possibly the gut inflammation is something separate to the joint inflammation. The frequency of the intestinal inflammation was similar to that frequency that we saw in that Crohn's disease study with the first-degree relatives. So that's quite interesting. And now this leads us over to studies. Again, another study that we've done here in Otago, where we really looked at the clinical presentation of those patients with ankylosing spondylitis and how much gut inflammation they have.
Yes, so thank you, Michael. So what we wanted to do was to see if there were non-invasive ways where we could identify patients who had asymptomatic bowel inflammation, who might go on to develop Crohn's disease or more overt bowel inflammation amongst our cohort of patients with spondyloarthritis. So in order to do that, we adapted a questionnaire called the Dudley Inflammatory Bowel Symptom Questionnaire from use in bowel inflammation to our spondyloarthritis cohort. And we looked at this initially in around 75 spondyloarthritis patients and compared that with controls, healthy controls, and people with Crohn's disease. And the interesting thing you can see here is that patients who were healthy and healthy controls had very low levels of bowel symptoms. This is a score out of 60 on a questionnaire. But patients with spondyloarthritis had significantly more bowel symptoms than the healthy controls, but in turn significantly less symptoms than patients with Crohn's disease, so a kind of intermediate group. And if we looked at this in terms of disease activity, obviously patients with Crohn's disease are going to have more bowel symptoms when their Crohn's is more active than when it's in remission. But similarly, patients with ankylosing spondylitis, when they had active disease, they had more bowel symptoms than when they were in remission. So perhaps there's a link between inflammation and these bowel symptoms. More recently, we looked at scores over 5 years in patients with ankylosing spondylitis throughout New Zealand. This is a cohort of around 365 patients throughout New Zealand, studied over 5 years. And over this period, you can see a remarkably stable level of bowel symptoms over that time, which seems to be unaffected by treatment over that time, which is quite interesting.
Have all these patients been exposed to a gastroenterologist?
Not yet.
Lack of treatment, Simon.
You'd have a lot of extra work to do, I think. So this is another thing. You might say, well, bowel symptoms, you know, could be a number of reasons for that. But if we look at the famous Bristol stool chart here, which hopefully you all have on the back of your door so that you can look in the toilet and see what bowel motions you had that day, whether it's sort of, what is it, sausage shaped with lumps or fluffy with edges on it. So these last two here, type 6 and 7 on the Bristol stool chart, are sort of diarrheal type presentations of your stool. And again, we can see that if we look at that with our patient group, they have significantly more loose bowel motions than the healthy controls, but significantly less than Crohn's. So again, they fall into that intermediate group.
What does that all mean? The question was then posed, the symptoms, the fluffy bowel motions they get, is that all something that points to some disease, some illness, some pathogenesis that we can find? So we took it a step further and we examined those patients' small intestine. So if you just look very carefully, will it work? It's not working. No. Oops. Oh. You did say something about we need to press this here. On this. It worked before, didn't it? No.
It's working. We've got help on the way.
Help. Our multimedia doesn't work. Yeah, we've done that. Ah, there we go. So if we look very careful at this, this is a capsule endoscopy movie, and you see the small intestine rushing by. Here, there was an ulcer, there's an ulcer, another one. Oh, yes, it's excitement. This is really primetime Netflix. There's another ulcer there. So this is what a capsule endoscopy looked like. There's just another ulcer passed by here. So this is capsule endoscopy, as I said before, a little capsule that these patients are swallowing that sends pictures every few seconds from the small intestine to a receiver. And then we look at this bit more subtle on this side here. There's something at 7 o'clock coming by, just been passed. There was one, another one. You just have to believe me, they are nice looking ulcers here, which makes the day of every gastroenterologist if we just suffered through about 2 hours of normal small intestine and then come into the terminal ileum and finally find these ulcers.
And these are patients with spondyloarthritis, aren't they?
This is a study, and the next picture will show you that this is a study on patients with spondyloarthritis, all these patients that had increased frequency of their bowel habit and some abnormal stools. So what this picture here is showing you is really just the findings on the small intestine. And if I go one further, this is a collection of data that thanks to Afra Khan, our registrar, who's been through these 16 patients again. And interesting findings, and we have to admit we haven't yet had much time to think about this very much. When you remember what Simon said earlier on, that obviously the bowel symptoms went along with the arthritis symptoms, this came through here as well. So we have again the DISQ here. Oh, I should use this thing here. No, we can't. Okay. Oops. Let's turn it back on. Thank you. So if we, yes. We have the DISQ here again, so the gut symptoms, and we have on this side here, we have the colitis symptoms. Where am I? Here, we have the arthritis symptoms. So with increasing symptoms of arthritis, so increase the gut symptoms. Not much correlation with the fecal calprotectin, this intestinal inflammatory marker. Also, I don't think a lot of correlation with what we find on capsule endoscopy. Colonoscopy in all of these patients was surprisingly normal, a little bit colitis here. Afra then provided us with this slide, which might be clinically relevant for all of us. So if we find patient with a CRP of greater than 10 or a fecal calprotectin of greater than 100, the likelihood of finding small intestinal lesions goes up with these increased inflammatory markers. So maybe, and this is something that we're going to talk in the last few minutes, maybe this is a very crude way of identifying patients where we need to look a little bit further for these small intestinal lesions and find these small intestinal lesions or patients that are prone to it. Current treatment options. Can we treat the spectrum? Can we go away from the silo mentality of just treating either or?
Yes, so maybe there are treatments which really make differentiating who has these problems irrelevant, because we can treat them all with one-size-fits-all therapy. So this is a little mixed message really here. So if we look at treatments which we commonly use for both conditions, there's a sort of mixed bag of results. So often one of the first biologic therapies that we use in people who've got severe ankylosing spondylitis or who have inflammatory bowel disease, particularly Crohn's, which is severe, would be to use anti-TNF therapies, monoclonal antibodies. So this is a study which, the only study really, which has looked at the coexistence of these two, and inflammatory bowel disease and spondyloarthritis, to see what the effect of treatment is. So if we look at infliximab, which is kind of the standard biologic at present for managing Crohn's disease, we can see that the number of Crohn's disease flares in a group of patients who have predominant spondyloarthritis falls dramatically in this group. So this is really treating both groups of patients very well. If we look at other common anti-TNF therapies used in ankylosing spondylitis, they're really no more effective than placebo in reducing those instances of inflammatory bowel disease. So from that point of view alone, we'd certainly perhaps be better thinking about using infliximab in these patients. In terms of ankylosing spondylitis, Thomas Jefferson really summed this up very well. We hold these truths to be self-evident. This is July the 4th, so I thought we'd better have a Declaration of Independence. We hold these truths to be self-evident that all TNF inhibitors are created equal. So if you look at the various ones which are used in ankylosing spondylitis, they're all just as effective for the articular manifestations of ankylosing spondylitis as each other, but clearly this is not the case when it comes to inflammatory bowel disease. And another difference in ankylosing spondylitis is that we need to keep patients on treatment forever. Once you stop, this is the cumulative probability of a flare. So very expensive. We have to keep people with ankylosing spondylitis on their biologic drugs forever, which is somewhat different to your situation.
Yes, but the world moves on, and despite living in New Zealand with having Pharmac that restricts our use of medications quite a lot, there are lots of medications that are currently in the pipeline. So it will be obviously interesting. Will our knowledge now of the genetics, of the immune system abnormalities, the microbiome, will this knowledge translate into a therapy, a treatment that will hopefully treat both of these agents? Now, Simon has already talked about the anti-tumor necrosis factor agents, infliximab and all the others. Most of them, or the first two at least, are available in New Zealand. And as Simon pointed out, at least in this one study, it looked like infliximab is the drug of choice. It's not quite clear why that would be. Certainly from a gastrological point of view, etanercept doesn't work in inflammatory bowel disease. Adalimumab works very well in inflammatory bowel disease. So why infliximab then would work on both is a little bit difficult to grasp. For gastroenterological disorders, we have these anti-integrins. Now, these are medications that stop inflammatory cells from entering the gut. So we don't think that those have much of a future in treating both of these conditions. They are very specific for gut inflammatory bowel disease. So I don't think those two drugs are anywhere in the future. More interesting is anti-IL-12, IL-23, and there's a drug that is already on the market by the name of Stelara. It will hopefully come to our to gastroenterology as well, but I think it's already in rheumatology.
No, not yet. But,
psoriasis?
No, not.
Oh well, sorry. It is in Australia, but I think that's a drug that holds a promise. When we look at coming results there. JAK inhibition, also I think it's very early to know whether these drugs will treat both of these conditions or just one, but there is another drug, secukinumab. They're all getting more and more difficult to pronounce. Secukinumab, anti-IL-17, which has so far been disappointing in gastroenterology. Is it different in rheumatology?
Very successful for arthritis.
Oh, there you go. This is getting more and more difficult. So just on a second last slide here on the ustekinumab or Stelara, very effective drug in Crohn's disease with high response rates. And mind you, patients that nowadays go into these trials are patients that usually have failed a lot of other medications. They are usually at the end of their tether with what's already on the market. So they are very difficult patients. But a 35% response rate at week 6 is fantastic for those patients. 42% remission rate at week 22 is even better. So this drug is really something that we are looking forward to, and we hope we get our hands on in the near future. Now, there's one anecdote on that before I pass it on to Simon again. We had one patient on this trial, a patient with psoriasis and inflammatory bowel disease. Unfortunately, in that patient, the drug didn't work in inflammatory bowel disease, but it beautifully cleared this patient's psoriasis. So from a quality of life standpoint, this patient was perfect. She showed me her legs, which not many patients do, but she showed me her legs and said, Michael, for the first time in years, I was able to shave my legs again, which for her was probably more important than she still was running to the toilet quite often.
Some studies coming up to be published on ustekinumab in ankylosing spondylitis, unfortunately, have been somewhat disappointing in that condition, although very effective in psoriatic arthritis. So interesting, a drug which we would expect to be helpful, not necessarily so. So just to summarize really at the end, what is the future for this overlap between spondyloarthritis and inflammatory bowel disease? I think what we need to do is to continue working to find clinical and laboratory factors which are going to help us to identify patients who are going to be at risk of significant problems in either direction, really, that co-risk. Then we need to perhaps try and elucidate the complex interaction between genetics, the microbiome, pro-inflammatory metabolomics, the gut and joint immune system, a very complex web of interrelated aspects, and maybe microbial profiling in the future will be helpful. We need to think a little bit about what targeted therapies will mean. It's been a bit disappointing that beyond certain TNF inhibitors, we don't seem to have a one-size-fits-all drug at present. But there are things, these JAK-STAT inhibitors in particular, perhaps hold the biggest likelihood of being helpful, such as tofacitinib. Thank you.
Thank you, Simon.
I'll start with the first question and then we'll go to people in the audience. One thing you didn't mention that seemed obvious as I was thinking about it was when you've got an arthritis, you get a whole lot of drugs that toxic to the gut. So how does that interact with the discussion that you just had?
Should I answer that?
Well, we could both. You go first.
I go first, yes. No, Barry, you hit the nail on the head there. This, it was on one of the slides, but I glanced over that. This makes studying these patients very difficult because obviously just taking a picture from the small intestine, finding small ulcers doesn't give you a diagnosis. And those small ulcers could well be the result of the non-steroidals. I used this against Simon and said, well, you know, you're trying very hard to give these patients gut symptoms so we can finally treat them.
Yes, and about a third of patients who take anti-inflammatories will develop some form of ulceration, and it's actually missed, I think, a lot in the general appreciation of what non-steroidals do. For whatever reason they're taken, this very high instance of ulceration caused in the lower gut. But it may be that being a bit cleverer about how we use anti-inflammatories can modulate that. So combining with misoprostol, an inhibitor of cyclooxygenase, and also using celecoxib, the coxibs. These are both shown to be ways of reducing that burden of inflammation in the lower GI tract.
Talking about quality of life, I think, which comes in there, Simon, that all of those patients, all of our 16 patients that were on these drugs were reluctant to stop them, because obviously we talked to them about that and said, can you stop them for 4 weeks so we have a true reading of your gut? They were all not happy about that, because they basically said we can't function without these drugs.
Put some alcohol on top and, yeah. Questions from the audience? John.
And on those graphs or pictures you showed of inflammatory bowel disease and where it occurs, you know, in places that have supermarkets, that's what you were attributing it to. But as you pointed out, there was a lack at the equator. So how do you distinguish that between being a latitudinal effect and being an effect of being on a supermarket diet?
It's hard to distinguish. There are many factors that play into this north-south gradient or south-north gradient, John. And one of the stories was also exposure to sunlight. Is it the vitamin D story that plays a role in there, that there's more exposure to sunlight? We know that inflammatory bowel disease is less likely in patients who are more exposed to sunlight than in other patients. So yes, I fully agree with you. There are so many factors that might not have anything to do with the westernization.
Okay, so it's 5:02, so it's time for us to get to the next session. So thank you very much. It's been a fascinating grand rounds, and I look forward to seeing the progress over the next 5 years. It'll be quite good.
Thank
you
you
very much.
Thank you.